Hello guys, how are you doing? Hope the exam is near and everybody is preparing well for that. Sorry for interval in between. I am actually on vacation and enjoying my life right now. So yes, this is something which gives me pleasure. So in between also I'm trying to find out some time to make some content on it and help you out. So let's go. Somebody asked me regarding the anxiety, depression, dementia, preoperative and perioperative assessment scenarios, and basically this will come in history station. So as you all know that if you have seen the previous videos regarding the history and communication, you know the basics, right? And it's pretty easy if you just stick to basics. You don't have to go anywhere else looking for something else about these stations. These are all the simpler stations in my perception, because here what you are going to do is not more on the medical or clinical background, it's more on the communication background. It's like people would say that these are like long stations, you can't finish them, but nobody is asking to finish you know I mean, you have to just stick to the basics, show your communication skills, and stick to the protocol or the format of the history taking. That's it, nothing. It won't be so much difficult. So what to expect? Basically, in these scenarios, there must be a patient given to you for preoperative assessment who is presenting with some sort of symptoms which are maybe breathless, tachycardia, perspiration, losing appetite, or something like that. That can be overlapped between anxiety or some organic disorder. So what you have to do is, you don't have to stamp it as in like you are only dealing with the case of anxiety, but you have to rule out what else it could be and what severe things it could be. So that is your primary purpose, that you are not dealing with a case who has some organic ailment. And how do you do it? You do it in regular practice, right? You ask questions related to the organic ailments, like if it is maybe some say case of COPD, then you would be asking the history of smoking, the exacerbations, coughing, cough production, expectoration. If it is pulmonary embolism, you would be asking resting tachycardia, breathlessness, tachypnea. If it is related to some heart problem, then you would be expecting some orthopnea, platypnea, dyspnea on exertion. All these will be your differential diagnosis. In the case of anxiety, if the patient is showing some breathlessness or is reporting some issues with the breathing, then you have to rule out all these things. That's what you have to do. And if you remember our history taking format, what you have to do is take history in detail about the primary complaint, and then you take the secondary questions, and then you go for the rest of the questions, which would be like personal history, social history, past medical history, surgical history, uh, drug history, allergy history, family history, so on. So what you have to do is just stick to the protocol. There's nothing different. Don't make a idea about this scenarios that they are pretty difficult. They are pretty easy. If you are forgetting couple of things, they are not going to deduct your marks for that. But you have to just show the empathy towards the patient, stick to the format, show your good communication skills. That's it. Then regarding dementia or depression, there might be a case where the patient is about to get discharged and showing the signs of depression. There can be a patient in OPD who is presenting either with depression, or a male patient presenting with erectile dysfunction, or a patient who had just had some surgery done and is showing some confusion, or maybe pre-operative case where you are about to take consent and you find that the mental status of the patient is not up to the mark, and then you have to stamp that, or you have to evaluate that this patient is whether eligible or like capable of giving a consent, or is eligible for discharge or something like that. See, we are not going to reinvent the wheel. There's lots of material available on YouTube. Even if you search thoroughly, you will find it. Even if not on YouTube, you may find some articles related to that. Where do you find difficulty is when you have lots of knowledge, which knowledge is correct and which is not, to identify that. That is one thing. Second, to check the quality of that. Third, to check the validity and appropriateness of that, particularly related to your MRCS Part B exams. So that's what I'm trying to help you here. I'm going to give you some links which will give you ideas about how do you do these things like mini mental state examination, abbreviated mental score, and the Glasgow coma scaling, etc. But how to apply it, when to apply it, and whether it is fitting in your scenario or not, that is to be decided by you. So you'll be given an exam scenario before entering the station. You have 1 minute in that, and it is pretty simple. Sometimes they give lots of details and it's difficult to finish reading that scenario, but don't worry, during the exam you have lots of adrenaline going through your veins, so it will help you concentrate on that, and you will do your best if you just know how to control your adrenaline. So basically, in cases of erectile dysfunction, again you will have long list of questions. Don't worry about it. Ask the primary complaint. If the patient is shy or not opening up, then you have to understand that how do you build a rapport with the patient, and then how do you deal with the questions coming. So here again, you don't have to ask each and everything as a primary complaint. You got it, that erectile dysfunction is there. The patient is reporting that he cannot have the erection which is good enough for having a fruitful or satisfactory sexual intercourse for him or his partner. So after that, express your empathy, and then go on the questions which are coming up in the secondary questions, like past history, medical history, drug history, and everything. That will cover each and everything related to the erectile dysfunction. You don't have to ask each and everything as a primary complaint. This is the mistake people do. They think that as it is erectile dysfunction, I have to rule out each and everything in the first session of the history taking only. No, then you will not be able to complete the history taking as per the format, and that is why you feel stressed that you have not finished the history taking. So what I advise you, you give couple of minutes for the primary complaint, as you have 6 minutes in total for history taking. Then go on to the secondary questions or the history taking format, and it will actually cover each and everything. If the patient's erectile dysfunction is because of some peripheral vascular disease, they will report in the medical or surgical history. If they have some issues related to diabetes, dyslipidemia, or any past surgery or any trauma, everything that will be covered in those questions. So always try to complete the particular format of history taking, then you will not have any issues with the finishing the history taking. Again, there is some scenario where the patient is like post-operative case or pre-operative case and showing some signs of confusion. So you will be given in scenario that the nurse has found that this patient is not behaving as per what is expected. Then you must be knowing then now what you have to do. So here you don't have to follow the particular format. I mean, here you will be given a scenario where you already know the patient is indo, you are going inside, then you just address them with their name and then start asking the question, and then you find that that patient is having some confusion or showing some signs of delirium, then go on, ask the permission. They will be cooperative. So you'll have, this is a role player basically. So what you have to do, they are looking for some keywords or signages from you. You have to signpost that now I'm going to start some questions regarding your memory or the status, or what will help me to understand the situation, where whether I can discharge you or whether you can give the consent or not, something like that. You take the verbal permission from the patient, start the questions. There are 10 questions in the AMTS, that is a basic examination for mental status. It's a mini because the name itself suggests abbreviated mental state examination or testing. Okay, so basically you have to understand that this is abbreviated, so this is going to give you the provisional idea whether the patient is actually having some problem with the mental status or not. If you find that yes, this is abnormal, 6 out of 10 is considered like okay. If it is score is below 6 or like 6, then you have to go for the detailed examination, which is MMSE. Again, it is mini mental state examination. So understand, this is again a mini examination. It's not a very detailed examination. So no one is expecting you to do a examination which is done by a neurologist or a psychologist, okay, or the psychiatrist. So what you have to understand here, they want to know whether you are aware of these things. You are aware that this patient is not eligible to be discharged or not eligible to give the consent. That is your primary concern. That's where you are showing the patient safety. That's the domain they are assessing. Second domain is your history taking or the medical clinical knowledge. Third domain is your communication with the patient and empathy and everything. So basically all of this is being assessed. It's not only the questions you are asking, they are being assessed. So people fall into this trap. They understand that all the questions I'm going to ask, they are important, and if I'm not asking these 100 questions, I'm going to lose marks. No, those 100 questions or 50 questions or 30 questions, whatever you're going to ask, they are allotted particular marks only. So you're not going to attain anything extra by asking too many questions. I hope you understand my point here. Okay, so basically again you have to rule out any organic element, and that should be in your differential diagnosis. So does it change your actions? No, a big no. As I explained, you have to do what you do in any history station, follow the protocol and the format of the history taking. Only difference here is like in cases of dementia and delirium, and you have to go for the AMTS, and if required, in AMTS score is like less than 6, then you have to do MMSE. So people are always scared about the AMTS examination. How do you actually remember in the stress of exam that asking those 10 questions? So see, lots of things do not have logic, and lots of things you have been like mugging up since you went into this medical school and everything. So I'm not here to tell you that there is some logic behind it or how do you remember it. You have to make some sort of like your own technique and then remember that. Those 10 questions you have to remember. There is no excuse for that. So how does it scare examinee? Because there is long list of questions and fear of not able to finish. Again, as explained previously, there is no need to finish everything, but make sure that whatever you do is you are doing it well. This is you must have, you just Google it out, the AMTS or MMSE. I have Googled it out and I got this, and this is very clear. So you have to understand that if you are going for the AMTS and you are not able to finish in 6 minutes, and you are not able to tell that patient is having really some organic, confusion or dementia, or the mental status score is less, and then I want to do mini mental state examination, there's no point. If you're not able to finish AMTS, MMSE is out of question. But they may ask you in the 3-minute Viva section, what is MMSE and what components are there and what questions do you ask in MMSE, okay? Or in certain scenarios, you will be given right away that this is the case and you have to start with the AMTS and MMSE. Then you have to remember MMSE also, okay? So people ask that whether I need to memorize the MMSE questions. Yes, I'm sorry for that, but you have to. There is no alternative for that. It's not very difficult if you like do revision 2 or 3 times before your exam. Your first reading is like around 2 months, right? Then your second revision comes in like last 1 month, and last 10 days of exam, 7 days of exam, you are going to revise each and everything again. So if you go through this 3-4 times, you will be able to memorize it, even if for shorter duration, like only till the exam finishes. That's also fine. You don't have to worry about it. Don't have to remember it always. After that, always the formats are available, checklists are available. You can just have it in clinical or the practical actual life. Then you don't have to keep them memorized or mug up the things. This is the Glasgow Coma Scale. It is not relevant here, but you have to understand that this is the similar thing which we do in trauma patients or head injury patients. The same kind of mental status examination, but this is relevant to the trauma cases. The other two are relevant in your non-trauma cases. These are the links. These videos I have seen before my exam and I have followed them, and they are pretty simple to understand. And once you understand them, you actually get the knowledge of, the layman terms also. How do you actually talk with the patient in these scenarios, and how do you assess these things is pretty clear after watching these videos. Okay, so I'll keep these links in the description of the video also. You can just refer to them, just watch them, and should be good enough for you to pass this kind of station in your exam. Don't worry too much about this. Don't go into unnecessary details. Just follow the protocol and format and communication skills. That's it. Enough. Nothing to be worried. If you like this video, please like it, subscribe and share among your peers. So I want to help as many as possible. Thank you so much. Have a good day ahead.